I think it's important for people to know that FASD is very common in our society. It is overrepresented in certain population groups, for example, the criminal justice system. In my experience, a high percentage of professionals who work in the criminal justice system have little to no experience with this disorder. So unfortunately, a lot of individuals who do become involved in the criminal justice system never receive an official or accurate diagnosis. And oftentimes, they're misdiagnosed with other types of neurodevelopmental disorders, neurobehavioral disorders, psychiatric issues, as well as a host of medical health conditions, which then can complicate the intake, the screening, the treatment planning, and even the discharge planning process, which then that person goes back in the community and they often are dealing with a host of disadvantages. So for example, they may have a difficult time finding housing, finding employment, and those are very important things for folks who are involved in the justice system to ensure that they line up so they don't have to go back into the criminal justice system. A lot of the clients I've worked with at the adult level are on probation or have been on probation, and the probation officers who really want to understand FASD do a pretty good job of modifying their approaches to this population. Unfortunately, there are some probation officers who do not have any experience with this disorder or have no interest in learning about this disorder, and just in my own observation, a lot of those clients slip through the cracks and oftentimes violate their probation, end up in court again, back in jail, sometimes prison, and then that revolving door continues for this individual throughout a good portion of their lifespan, unless they have people advocating for them who understand the complexities of FASD and can help them receive an accurate diagnosis. And then when you receive an accurate diagnosis, treatment can be modified and other types of supports and services can be put into place to really help this individual thrive throughout the rest of their life. The research literature that focuses on FASD has at times researched theory of mind deficits. And even amongst the individuals who understand FASD, at least in my experience, don't understand or haven't had a lot of training on theory of mind. And theory of mind is so important for just overall social understanding. So someone who has deficits in theory of mind will oftentimes have a really difficult time understanding the thoughts, the wants, the needs, the emotions, intentions of other people. They have a difficult time reading social cues. They may have a very difficult time detecting deception in other people. So this is one layer as to why this population is extremely vulnerable to victimization and being taken advantage of. When it comes to problematic and criminal types of behavior, this is an area that I think it is worth exploring more, particularly if the individual becomes involved in the criminal justice system and is evaluated by the court. Because if this deficit is not detected, oftentimes this person could present, in some cases in the courtroom, as cold and callous and removed, and it may appear that they don't have any empathy when in fact these deficits are a direct result of the prenatal alcohol exposure they sustained in utero. So again, very important to understand the topic of theory of mind and how it relates to just overall social decision making and just interacting with other people in all types of settings. Well, if you look at the research literature, there is a sizable minority of individuals on the FASD spectrum who have engaged in inappropriate sexual behavior. And I think it's important when you are determining the reasons why this is happening, you need to look at intent. What was their intent? Were they lacking that cause and effect? So many folks with FASD function a lot lower than their chronological age. So if you're working with a 20-year-old individual chronologically who has FASD, oftentimes they may function as a 15-year-old or a 12-year-old or a 10-year-old. So from a court of law standpoint, it would be very important to understand that. And that may come into play during sentencing or as a mitigating factor. The last thing someone wants to do is put someone with FASD into a group of other individuals who are much more higher functioning, where that individual goes in there and is taken advantage of, or hears stories from other people and is very suggestible and gullible and sometimes naive, and learns other things from other people that they will now start carrying out in their day-to-day life. So it's very important to evaluate these individuals and really understand the complexities of this disorder, what deficits they're dealing with, their limitations, but also capitalize on their strengths. In my experience, these individuals do much better on a one-on-one type of intervention setting rather than a group format, unless the group has been modified to take into account their FASD-related deficits. Because if not, treatment as usual for this population often does not work, because they're thrown into a treatment program with other people who may not have the deficits these individuals are dealing with. And clinicians and therapists and psychologists and social workers oftentimes don't have training in FASD, and they don't detect when some of these red flag indicators are at play. So a good example is if you're in a group setting, these individuals really struggle with information processing deficits. So the therapist may ask a question, and the person with FASD may need 10 to 15 seconds to respond. If a clinician doesn't detect that, they may have rapid fire questioning, which then will overload that individual's cognitive capacity, shut down emotionally, and sometimes they could withdraw, or they could be hyper aroused and they start acting out emotionally. So there's a lot of layers to this that clinicians need to take into account. And in a group setting, it can be very tricky to manage all of that. So just in my experience, I think that's why individual approaches are best, through a multi-systemic lens, working with multiple providers who have various expertise. Because people with FASD typically deal with co-occurring mental health issues, but also they deal with co-occurring attachment problems. They can deal with a high rate of sleep disorders and other kinds of medical health issues. So it's not just treating the mental health component, but really looking at the neurological component to this, as well as the physical health deficits these individuals so often deal with. Most of my experience working with clients with FASD is in the adult population. And if you look at all the research, all the training, a small amount of the research is focused on adults. Most of it's on kids and in utero. And when you're working with adults who become involved in the criminal justice system, there's not a lot of research out there. Yes, there is some, but if you compare it to all of the FASD literature, it's really a drop in the bucket. So there's not a lot of guidance for clinicians as to how to work effectively with adults. There is some, but we need more work. And anecdotally, I am seeing, at least in some of the adult populations I've worked with, they have high rates of traumatic brain injury as well, where they've sustained a brain injury at some point in their life on top of the prenatal alcohol exposure. And that could be a result of getting in a fight, getting hit by a car, being clumsy and tripping and falling and hitting their head. And now you have a brain injury on top of the FASD. It becomes even more confusing for a clinician to really detect what's going on with this individual. So at the very least, if you're working with someone who has suspected or confirmed FASD, it's imperative to refer that person to a cognitive testing facility, a neuropsychological testing facility, who can really help gather data and really help the professionals who work with that client become more informed, because we want to understand how that person processes information, how their memory works. Are they dealing with sleep-related issues? Could that be a factor as to why they're not doing well in treatment and they're falling asleep because they're just so fatigued and they can't take in that information? And those are just a few of the areas you'd want to look at, in addition to their executive functioning capabilities, which really drive the bus with behavior. And then their adaptive functioning capabilities. How do they function in day-to-day life when structure and supports aren't in place? And a lot of times these individuals really struggle in that capacity when they don't have the right supports or services. If it's a mild head injury, they may not show up on a scan, but you really need someone who understands, I think, brain injuries, trauma, sleep disorders. I mean, it just gets so complicated to work with this population because it's not just the FASD this population's dealing with. The overwhelming majority, if you look at empirical-based research, has a diagnosis of ADHD or looks like they have ADHD. The overwhelming majority of these individuals have attachment-related problems, sleep-related disorders. Anecdotally, at least in the clients I work with, a number of them have had traumatic brain injury histories at some point throughout life. And then on top of the FASD, was the mother also smoking cigarettes during pregnancy, on prescription medications, other types of drugs? Was she sleep deprived? Was there any nutritional deficits at play? Was there high levels of cortisol going through her system because she's under a great deal of trauma? All of those things can negatively impact the developing brain, which can just further complicate the accurate diagnosis of FASD. And those are some of the reasons why this population never receive an accurate diagnosis, because it looks like so many other things. Without early intervention, accurate diagnosis is key, and that's according to research as well. But common sense things too, ensuring they're eating properly, they're exercising, managing stress appropriately in a stable and calm and structured environment, making sure that whoever's working with that individual, they understand attachment theory and trauma-informed care approaches. Ruling out any sleep disorders early on in childhood, because sleep disorders, particularly untreated sleep disorders, can really mimic ADHD-like symptoms, oppositional defiant disorder. So unfortunately, some of these kids get labeled with some of these behavioral disorders when in fact there could be an underlying sleep issue going on. And when children don't sleep in general without FASD, they can look like they have ADHD, they have a hard time concentrating, they can be irritable. And the last thing you want to do is start medicating kids who don't need medications and labeling them with disorders that they don't have. So really peeling back the layers and finding out what's going on and establishing goal plans, treatment plans, intervention plans, case management plans, family intervention plans too, and providing the entire family system with supports and services and education around this complex topic. There are some diagnostic centers in Minnesota and around the country. Obviously, we need more. We need more for adults. We need more for individuals involved in the criminal justice system. And even backing that up, not just diagnostic centers, but informing agencies who work with at-risk individuals about screening protocols, being aware of red flag indicators, being aware of where they can refer to when they suspect someone has FASD, learning how to modify the way they talk to these individuals, how they phrase their questions, how they develop their goal plans, and really looking at that through, again, a multidisciplinary lens, not just for the mental health arena or the medical health system, but for the educational arena, for child protection, for domestic violence shelters, homeless outreach clinics, all facets of the criminal justice system, because unfortunately so many of these clients do end up involved in many of those different systems. And when these systems aren't working together and collaborating and talking, these clients really do fall through the cracks. This population is prone to be suggestible, and they're prone to confabulate. And when I use that term confabulate, that's false memory creation. So a good example would be if someone with FASD who's been charged or convicted with a sex crime is now referred to group sex offender treatment, and they're in there with other individuals who are also considered sexual offenders, but none of the other individuals in there are on the FASD spectrum, and maybe many of them are very high functioning. There are some individuals with FASD who, when they hear a story, they then adapt it to their own selves, and they believe that they are actually doing that. And that can be very complicated because a false memory feels like a real memory. And those individuals, a lot of times, don't know how to distinguish between what is a false memory and what is a true memory. So now they're reporting something to their probation officer or their clinician that they did when in fact they just heard it in a group setting and now just reporting it as fact that they did it when in fact they did not. So it becomes very complicated in a group setting, particularly for sex offender treatment, because these individuals are required typically, if they're convicted and have to go to treatment, to complete these treatments successfully. If they don't, they're often violated and have to go back to jail or prison. So in my opinion, I think individual work with this population is so crucial at first. Now, if you had a group that was set up with all individuals with FASD who are functioning at the same level or close to the same level, with a clinician who has experience and advanced training in that area, there could be some success in that. But when the clinician does not have training in this area, a lot of negative things can happen for that individual. And the professional isn't doing anything deliberately. They just might not detect some of these red flag indicators that this individual may be dealing with. And that's just another layer as to why this population often does not do well in types of treatment settings that are treatment as usual. And then they slip through the cracks and they're back involved in the justice system. And they have a very difficult time getting traction when they continue to be violated on probation for a lot of technical things. Maybe they show up to treatment late. Sometimes I've had clients who show up to their individual sessions a day early or a day late. They have profound memory impairments in some cases. They can deal with sensory issues. So if they're in a group setting and they're taking in a ton of information, they can become overwhelmed quickly. Maybe there's bright lights in the room. They become overwhelmed with bright lights. Maybe certain types of sound really negatively impact them. So then they shut down and then treatment continues, but they're only catching a third of what was reported in treatment. So that would be another layer as to why some of these individuals aren't successful. The other layer to consider, again, is that sleep deprivation. There's been so many clients that I work with who have sleep-related problems who may not be able to go a full session. Maybe they need to take breaks every 15 minutes or every half hour, and they need to walk around or move. Then they come back and they're recharged. If they're sitting in a group setting for an hour and a half at a time, oftentimes their brains don't have that capacity to take in all of that information without more frequent breaks. Just in my experience, working with adults individually who are dealing with mental health and or chemical health issues seem to do better one-on-one, where you can modify your approaches much more succinctly to match that client's developmental and emotional capabilities. You really want to match them on where they're at with language and communication abilities, taking into account their processing speed abilities. I had a client I worked with a few years ago who had suspected FASD, and when I would ask this individual questions, it would literally take her about 10 to 15 seconds to respond. So it's imperative to slow the pace down, take into account all of those different variables that this population so often deals with. And the main variables that I see are attention-related problems, issues related to memory. They can be very suggestible and prone to confabulate, high rates of sleep problems, attachment disruptions, and trauma-related issues at various times in their life. Anecdotally, and this isn't talked about that I can find in the empirical-based research for FASD, a lot of my adult clients seem to be dealing with digestive health issues as well. And if you understand the gut-brain health connection, it really can impact their mood and their behavior and their cognition. Now, there's a lot of research published on the gut-brain health connection as it pertains to autism, but I'm not aware of any research that specifically looked at that within the realm of FASD. But I am seeing it anecdotally with a lot of my adult clients that have profound digestive health issues that can really impact their mood and energy and cognition. It is not a black and white answer. There's a lot of gray area. Obviously, public safety is extremely important, But if an offender with FASD is thrown into a prison setting in a general population, they're vulnerable. They're often victimized in a prison-related setting. Depending on the crime, obviously, there's a lot of layers to this, but these individuals would do better in kind of a mental health modified court setting, oftentimes a more structured kind of approach to community supervision that takes into account all of the other variables that this individual is dealing with. If someone with FASD does go to prison, obviously they would need certain supports and structures to be successful in there. Putting them into a certain type of group or treatment program that has been specifically developed for folks with FASD would be ideal. But to back that up, obviously early intervention would be key, and to be aware of the red flag indicators and all of the other complexities these individuals deal with to help them not become involved in the criminal justice system in the first place would be ideal. And if you look at the research, the first types of crimes these individuals usually get involved in is theft-related issues, not understanding property or ownership. And that really goes back to the discussion about theory of mind. If they don't understand the thoughts, wants, feelings, emotions, intentions of other people, they may not understand the value of ownership or property, and they may take something that in their mind they're not stealing. They don't understand that cause and effect. And a lot of these individuals, that's one of the first ways in which they become involved in the criminal justice system. So if the criminal justice system really recognized that early on, maybe there would be certain diversion programs and getting a support and services in place early on before they become repeat offenders into adulthood, and then some of their crimes increase in severity, which then can lead to a host of other issues. Because if someone is repeatedly involved in more severe types of criminal behavior, they're often exposed to other types of traumatic events. They could have a higher risk of traumatic brain injury on top of the FASD because of poor choice making, getting into fights, doing things they should not be doing. Unfortunately, there's elevated rates of substance misuse in this population too that can really exacerbate some of these issues we're talking about. There's smaller studies, 10 to 24%, but it's hard to generalize that. But there's a sizable minority of people in prison with undiagnosed FASD, I can say that. There's a lot of people in prison, just anecdotally and talking to professionals and caregivers around the country, who really believe that there are absolute elevated rates of FASD within the criminal justice system. Unfortunately, the overwhelming majority of these people never received an accurate FASD diagnosis. Because FASD at the adult level and the criminal justice level, there's not a lot of options for treatment, for screening and assessment. Now there is some, we need a lot more, and I think it should be in place in every prison, every jail, every probation center in the United States, because you're probably coming into contact with individuals with undiagnosed FASD on a semi-regular basis. Considering the rates of autism in the general population and compare that to the rates of FASD in the general population, FASD is more than double that of what autism is. And autism has a lot of different funding options, treatment types of interventions, research dollars. If FASD got at least the same amount of that, I think we would be in a much better position with understanding and recognizing this disorder. There are some states that now require law enforcement officers to receive training related to autism. I would love to see every state require law enforcement officers to also have training in FASD. I would love to see every law school, every nursing program, every criminal justice program, every psychological program, social work program require training and education in FASD, because you are coming into contact with this disorder if you're working with clients, most likely on a semi-regular basis, but unfortunately you may not know that because the individual comes in with a long list of other diagnoses.